Hello, friends. At the onset, I would like to thank Dr. and the entire team of CXL Meet for this opportunity. I'd like to share my screen. My talk today is current biomarkers in keratoconus and cross-linking. These are my financial interests. I do not have any direct financial interest to the presentation, what I'm going to make now. Let's look at biomarkers in impact in health, KC, and cross-linking. This is one of my favorite paintings by Phil Lukes. Look at a very, very inquisitive physician trying to find a cure for this child. It's always been inspired me about the look of the physician. We have to start looking outside the box other than the regular type of investigation modalities what we are used to. So the whole idea is to try to see more into the molecular aspect of the disease. In this regard, we at Narayanathala, Bangalore, we set up a center for unknown, where we mix the clinician, the genetics, the biomarkers, and AI, and try to bring in a more personalized care in all the disease we treat. And keratoconus is one of a major focus. And this is what a physician would look at today. Curiosity in a physician with the imaging, plus a lot of other molecular data at his disposal. What's the first cardinal rule when we started? Is never discard anything what can be a potential use as a biomarker, whether it's an epithelium, the lenticules, or the blood, everything, or your Schirmer strip. And try to mingle with people who speak different language than yours, the immunologists, the people who are in different walks of life. And that's when a clinician starts working with them. And we have probably one of the largest biorepositories of all the tissues, especially more than 7,000 to 8,000 of keratoconus samples stored over the last 10 years. So whenever you want to do any great work on molecular or genetics or any of the signaling pathways, you have to exhume those molecules hidden in those cures and start exhuming in them like a mummy and then start studying them. You can do a lot of studies on them. You can do a gene expression, proteomics, molecular data, immune profiling, microbiome. Multiple things can be studied with them. So what I'm trying to talk today is a summary of my work of the last 10 years of working with all these molecules. And this is a paper which we published in APJO, which looks at the mechanism, the biological, environmental, the cytokine, and how they have an impact on the collagen in a cornea. Let's look at the biological stimuli. The immune mechanism lives in harmony with the ocular surface. And there are a lot of those immune cells which are always trafficking, which is on your ocular surface. That's why you call immune trafficking. This immune mechanism of ocular surface cells, when the harmony is tilted, then they start having impact on different types of cells, end organ cells on the ocular cell, epithelial, keratocytes, or endothelial cells. So how do we, looking at this immune landscape, how do you look at friendly versus non-friendly ones? So we did this very unique study where we did a wash of the ocular surface like this, and then collected those water, preserved in paraffin, and then started looking at those cells. Because once you put in paraffin, those cells are, you have freeze those cells in exactly the state as they were in ocular surface. And we started looking just like face recognition, we started looking cell type recognition, flow cytometries were all done to look at the immune cell surveillance. And this were some of the equipments which were used. And this is a small animation. This is an ocular surface. You do the wash, you preserve them with paraffin, and then you transport to the centrifuge flow cytometry and divide them into different cells. What we found was keratoconus had a diffuse and different cell lines compared to the normal versus the grades of the keratoconus. And these immune cells have a huge impact in the immunoregulatory and amplification processes. That has an impact on and they are completely different compared to what we see in the dry eye, which is very important because many times they may be coexisting. Many times one drives the other, but still the immune cells are extremely specific to a type of a disease, is what this paper says. We look at also the factor of IgE. IgE is probably one of the most important factor which drives itching. And we have published this work where, basically if you have an ocular allergy or all my keratoconus patients, I do an IgE level. And if there is a specific IgE which is higher, then we try to encourage them to meet the immunologist and see if they can figure out what is the allergen which is driving the disease. For example, there's a 14-year-old girl with keratoconus grade 2, first presentation 2017, high rubber. We did the imaging. This is the keratoconus, and the IgE was 2,500, less than 100. She was advised complete allergen test, and what we found was she's allergic to these things, cotton, dust mites, and they also do a sublingual immunotherapy because it's a very high level of IgE. And what we found 1 year post-op is she stopped rubbing, and you can see that the cornea is stable, and you can see some amount of stabilization and flattening. That means once you stop the eye rubbing, the keratoconus has a tendency to stabilize itself, so it can actually, the new collagen can start. This is a very important finding. So that IgE is a very important step in your treatment. What are the environmental insults? Environmental insults could be driven by hormones or vitamins. We have to manage the ocular inflammation. And vitamin D, one of the factors which can drive the ocular surface inflammation. This is a new paper of ours which looks at the factors of what happens in the vitamin D and vitamin D receptors on the corneal surface. And what we found is vitamin D receptors is lower in a dry eye disease. And these vitamin D receptors are also very low in the keratoconus patients, and according to the grade, and both in the cone versus the periphery. So it is very important to understand that low vitamin D induces inflammation. And we created this experiment where when there is a low vitamin D receptors, then there is more of oxidative stress, and that causes change in the collagen and lysyl oxidase. And just to show that there's a link between inflammation, oxidative stress, vitamin D receptors, and change in the and it is very important that vitamin D itself would change the whole ocular surface milieu. It can change the MMP9. It can change. So vitamin D and IgE, according to me, are one of the two most important factors you have to consider in a pre-op evaluation of a keratoconus patient, because you can see from these two patients, one is IgE, and you can see that it has a huge impact in the inflammation, especially the MMP-driven one, because you can see the ELISA plots here. And vitamin D in experimental model has a tendency to increase lysyl oxidase and the collagen. So what happens to the inflammation? This was one of the first papers we published, which looks at the high level of, and we use cyclosporin to stabilize the MMP9. A different type of molecules, MMP9, chemokines, all have an implication in progression of a disease. We also looked at autophagy, and we used trehalose, which is there in many lubricants, tears, and many other. Trehalube is one of the drops in India. And no financial interest, I wish I had, but these molecules have an impact on changing the autophagy, the cell housekeeping mechanism, and then tries to bring a different kind of ocular surface regulation. We look at all the changes which can cause, and this has a huge impact in customization. The lysyl oxidase and collagen are the two most important factors, which is very important both in keratoconus and also the outcome of the disease. This is what I said. When you use BAPIN, which is a LOX inhibitor, you can see that the collagen completely degrades, which means that any inflammation is important to maintain the strength of the cornea. If the inflammation is, the strength becomes weaker. And lysyl oxidase, you can see from this paper, Journal of Biological Chemistry, it's very important to hold the collagen tight. If there is inflammation, then the collagen, lysyl oxidase is not there, the collagen starts changing. And we have published few papers on this regard, the change in the collagen and lysyl oxidase, and even differential between the cone and the periphery, can see that the change is distinct, and the grades of keratoconus also to change. An outcome of cross-linking is dependent on the amount of locks you have. And this is what I said, a good locks, good outcome, poor locks, a poor outcome is what those papers said. And if you have excessive of locks, for example, if you do a cross-linking on a healthy eye with lots of locks, you probably end up with more flattening and more haze, because you have already a lot of corneal fibrosis, corneal strength there, trying to create more fibrosis or more unwanted cross-linking. This is my hypothesis. This is a paper we spoke about where we had preserved the lenticule in a SMILE patient who developed ectasia, and we found that genetically it caused changes. How is LOX related to inflammation? We created this experiment on the human cell lines, and you can see that we created an inflammation in this collagen, and these inflammation suddenly drop, increase in the MMP, change the lysyl oxidase. You can see that when there is an increase in MMP9, the lysyl oxidase dropped and the collagen dropped. Just a classic example to say that when there is inflammation, there is a drop in strength of the cornea. So inflammation reduces the strength. So this is examples, and this has been proven in the clinical arms also. But this experiment, when you see that these, so how do we identify these biomarkers? It is very important that we have to identify this. And how do I apply this to the clinic? So we have come out with a new point of care diagnostic kit called biomarker pathfinders. And this is all the known culprits of progression, known culprits of inflammation, known culprit which can dampen the collagen or change the collagen, known culprits which can cause corneal haze are all included in this. In TNF alpha, ICAP1, the eye rubbing molecules out here, and MMP9, VEGF. Just all the things which is there in it. And what we do is we take in the Schirmer strip, and these Schirmer, after that, it's collected with the Eppendorf cubes, and you use a buffer. You extract the proteins out there, and then this is done by one of my fellows. And once you do that, extract the proteins, you use it in this wells of this kit, and once you do that, you read it and you just put it into this biomarker pathfinder. This used in cancer also, kind of tools, and you get this report like this, and it will tell you what is the reference level and what is the patient's level of this. So higher level of TNF alpha cause inflammation or corneal scarring or excessive flattening if it exists pre-operatively. And this is what I use in every patient in my OP. We want to bring it into a commercial system as early as possible. We should have done it last year, but hopefully next year, we want to produce it. So these molecules will tell you. We are also trying to bring in LOX. LOX is a different kind of protein, so it's a little challenging, but hopefully next year, we'll also have the lysyl oxidase also in this. So that is our dream, to have everything in a panel. Way forward, based on understanding of a molecular immunological profiling, we want to get into the gene therapy. And we are working on gene therapy for at least 5 different retinal conditions: Stargardt's retinitis pigmentosa, choroidemia, and other areas, and muscular dystrophies, the skeletal muscle dystrophies. We also, this is one of our, the class vector production center and gene therapy unit, which we have in our hospital. And this is an example of how the vector, this is a class 100 room, and how the vectors are produced. And one of the areas of target we started looking at is the collagen and lysyl oxidase gene therapy. And this we feel that has got a great potential. And we started doing the gene therapy on the lenticule, which we have taken out from SMILE procedures, and use the gene therapy adenoviral vectors to see if there's a change. You can see that the huge increase in the collagen, and it also changes the MMP9. That just shows that there is the lysyl oxidase gene therapy can be a potential areas of work. And this is what we started, this areas. What you can see is a change in the collagen. And this is something which we are very excited, and we want to bring it to the mouse model, and is exactly showing the same results. And now we move to the rabbit, and then probably human form. In probably then we're going to use the drop format to make it work. So what's the future? The future is about understanding the molecules so that you do a personalized treatment. Role of IgE, role of vitamin, controlling the vitamin D, IgE, and also taking care of inflammation is very important. Even autophagy, like role of in your lubricants, is very important. There's a different response in cone and periphery. One size of treatment not work. AI and biomarker detection is going to be the future. And I have a strong bet that the gene therapy can really create changes in the way we treat keratoconus molecularly and cellularly. These are all a group of scientists who work with me, and all the departments I'm associated with in bringing this work in front of you, and all the consultants who help me to make this happen. Thank you, and hopefully to see you next year with show, and by then we'll have some exciting data from the molecular and genetic. Thank you.